Hello, good day. My name is Montes. I'm a fertility specialist in Bogota, and today we're going to speak about fertility preservation protocols. In recent years, the demand for fertility preservation for oncological and non-oncological reasons, as well as personal reasons, has increased dramatically, and meeting this demand will prove a major challenge in coming years. Currently, embryo cryopreservation and mature oocyte cryopreservation after ovarian stimulation are the only methods for fertility preservation endorsed by the American Society for Reproductive Medicine. However, many experts believe that there is now enough evidence to support the use of ovarian tissue cryopreservation as a valid and effective technique for preservation of tissue instead as just an experimental approach. Of all the available means of fertility preservation, the oocyte cryopreservation by means of vitrification, that is a method where you really rapidly freeze the embryos, provides the highest yield not only for women with benign diseases or those seeking fertility preservation for personal reasons, but also for women with cancer, if the treatment or the chemotherapy cannot be postponed. Ovarian tissue cryopreservation is especially indicated for adolescents and women in whom cancer treatment cannot be postponed as or less than 2 weeks. The term ovarian reserve is typically used to refer to the population of primordial follicles. Initiation of the resting primordial follicles reserve begins in the fetus when 100 to 2,000 primordial germ cells colonize the genital ridges and enter a massive proliferation process that results in 7 million potential oocytes at mid-gestation. In the human ovary, approximately 85% of these potential oocytes are lost before birth. The decline in the number of follicles continues throughout the reproductive life, during which time approximately 450 ovulatory cycles occur, with the majority of follicles undergoing atresia during the growth phase. The serum levels of anti-Mullerian hormone, which is correlated with the number of primordial follicles, but is not a direct product of these follicles, can be used to estimate their reproductive lifespan. As we can see here, I wanted to show you this graphic, and I usually use this graphic with my patients as I try to explain them all this that I have told you. That at the beginning, when she's born, she has around 1 to 2 million of eggs. At the age of the onset of puberty, she has around 350 to 450. And at the age of 25, more than half of those eggs have been used. And at the age of 30, only 12% of the eggs remain, which means that with age, this is not going to stop, but instead is going to decrease rapidly after 35 years of age. That's why we call advanced maternal age after 35. And the reason is because the increase of miscarriage rate and also the diminish of monthly pregnancy rate that diminishes after 35 years old to 12%, after 40 to 5%, and after 45 to 1%. And when the average onset of menopause starts, is because the ovarian reserve is less than 1,000 eggs. Fertility preservation remains a challenge, particularly in the case of hematologic cancers like Hodgkin lymphoma or non-Hodgkin's lymphoma and leukemia and breast cancer. These cancers constitute the most frequent indications for fertility preservation, since chemotherapy, especially with alkylating agents, agents, radiotherapy, surgery, or a combination of these treatments can induce premature ovarian insufficiency in some circumstances. The ovaries are very sensitive to cytotoxic drugs, especially alkylating agents, which are likely to cause gonadal dysfunction. Cyclophosphamide is the alkylating agent that causes the most damage to oocytes and granulosa cells, and it does it in a dose-dependent manner. The pelvic radiotherapy is also known to cause premature ovarian insufficiency. Indeed, the human oocyte is very sensitive to radiation, and a dose of less than 2 GI is estimated to be sufficient to destroy 50% of primordial follicles. Ultimately, the probability that premature ovarian insufficiency will develop after chemotherapy or radiotherapy is related to the ovarian reserve. This reserve can vary enormously from one woman to the next. Fertility preservation should also be offered to women with certain benign conditions that carry the risk of premature ovarian insufficiency. Many autoimmune and hematological conditions sometimes require chemotherapy, radiotherapy, or both, and sometimes even bone marrow transplantation. Other conditions that also impair future fertility, such as the presence of bilateral ovarian tumors, severe or recurrent ovarian endometriosis, and recurrent ovarian torsion, can be related to indications of fertility preservation. The ovarian endometriomas led to reduced ovarian reserve. Local intraovarian inflammation induced the presence of endometriomas, and also has been shown as a trigger follicle burnout, characterized by activating follicle recruitment with subsequent atresia. Moreover, increasing evidence shows that performing cystectomy on endometriomas may cause considerable damage to the ovarian reserve. So fertility preservation should certainly be contemplated in case of recurrence after surgery. Turner syndrome and a family history of premature ovarian insufficiency are additional indications for fertility preservation. There is compelling evidence that certain forms of premature ovarian insufficiency have a genetic cause. The largest group of women seeking fertility preservation consists of those who wish to childbearing for various personal reasons. So usually around 20% of all the patients right now preserving fertility are related to the first malignant and non-malignant conditions. But the personal reasons, as age and postponing childbearing, are the most common causes for fertility preservations around the world. And when we speak about the fertility preservation, we usually speak about the ovarian follicular waves. And the thing is that recent research has suggested that recruitable antral follicles are continuously present in the ovaries during the menstrual cycle. And ultrasonographic studies have demonstrated that multiple cohorts of waves of 2 to 5 millimeters of follicles are recruited continuously during a menstrual cycle. A wave is a synchronous growth of follicles that have a similar diameter. Waves of follicle development have been documented in healthy women using ultrasonography. 70% of patients have 2 follicular waves, and 30% can even have 3 follicular waves. Women with 3 follicular waves may have longer menstrual cycle compared to women with 2 waves. The follicular wave that emerges in the early to mid-follicular phase is ovulatory, while the waves emerging in the luteal phase are usually anovulatory, as shown here and here. The follicular waves could be recruited by constantly high concentrations of FSH. This new knowledge about ovarian function, and in particular the theory of a multi-cyclic development of follicles during the menstrual cycle, resulted in the prospect of a new approaches to ovarian stimulation, and in particular the random start ovarian stimulation protocols, namely the administration of exogenous gonadotropins randomly on a day of the monthly menstrual cycle. In parallel with these new theories in ovarian stimulation protocols, advances in vitrification of embryos and oocytes has allowed important progress to be made towards a new concept of a total disarticulation between ovarian stimulation and embryo transfer. As a consequence, new ovarian stimulation protocols can be proposed to those patients who could potentially benefit from it. These are useful particularly in cases of oncology patients seeking fertility preservation who may present at any stage during the menstrual cycle. Adhering to the convention of initiating controlled ovarian stimulation at the beginning of the follicular phase may result in either significant delay or cancer treatments or foregoing fertility preservation because of time constraints. Of course, these new protocols may also be useful to women who want to preserve fertility for non-medical reasons, where double stimulation protocols might help with oocyte embryo accumulation. It has been suggested that double stimulation might serve as a useful strategy for poor ovarian response patients where accumulation of more oocytes in a short time could improve outcomes. So when we talk about these type of protocols, I wanted to divide it in three ovarian stimulation protocols for this type of patients. One is that when you have enough time, you can use the conventional stimulation protocol. But if you don't have enough time, you could do a random start protocol. And as I already have spoken, using the follicular waves means that you can start at any moment of the cycle. And the double stimulation would be, well, maybe useful in patients where the poor ovarian reserve or the poor ovarian response might be the case. So when we need to start the random start, we speak about the need to start ovarian stimulation on any day of the menstrual cycle. Doesn't matter when was the menstrual cycle. She's gonna come to us in any day of the cycle, and she's going to tell us that she has cancer and that she needs to preserve fertility because she's going to start a cancer treatment. So this part of the process, the fertility preservation for cancer patients, has become essential in oncology care. Cancer treatment, especially when you use alkylating agents such as cyclophosphamide or total body irradiation prior to stem cell transplantation, is often cytotoxic and may result in depletion of ovarian follicles with subsequent subfertility or infertility and ovarian failure. The ovarian stimulation for embryo oocyte cryopreservation in postpubertal girls and women with cancer is the only technique approved, again, by the American Society for Reproductive Medicine. All other methods of fertility preservation, such as ovarian tissue cryopreservation, ovarian transplantation, in vitro maturation of immature oocytes, and the use of GnRH analogs are still considered investigational. Although ovarian tissue cryopreservation is the only possibility when the cancer treatment cannot be postponed, but this topic is beyond our lecture. Additionally, ovarian stimulation is initiated at the start of the follicular phase, but this method might require several weeks depending on the patient's menstrual cycle phase at the time of the initial visit. The theory of multiple follicular waves gives us the possibility of doing a random start. And this is an attractive approach for cancer patients. In cancer patients, there is no need to achieve synchrony between ovaries and endometrium, and there is no fresh embryo transfer, thus allowing us to do the random start protocols. Depending on the timing of presentation in relation to the menstrual cycle, we can divide it into starting the control ovarian stimulation in early follicular phase, which is almost as a conventional treatment or a conventional ovarian stimulation protocol. But she can also be in the late follicular phase, or as we will talk in the next slide, in the luteal phase. So when the patient comes, we can see her and do the ultrasound to see how her follicles are in which measure are they. And you can say that the early follicular phase is when you have less than 2 follicles of more than 12 millimeters, or if the progesterone level is below 2 nanograms per milliliter. The early luteal phase is defined as presentation within first 7 days after ovulation, and the late luteal phase is presented when in the last 7 days of the menstrual cycle. The late follicular phase and the early luteal phase are the most challenging time for random start stimulation protocols. And the reason is because in those moments, you actually don't know or cannot be sure that the response is going to be the adequate for the patient. So what I recommend to do is that in the initial visit, you should ask for her last menstrual period. Do the ultrasound and see how the follicles are. If the patient is in the late follicular phase, well, she already has a dominant follicle, which means that you can trigger the ovulation sooner, or you can inhibit the whole process of ovulation using analogs, a GnRH analogs antagonist of GnRH to inhibit the dominant follicle. After that, you can start the gonadotropins, and you can start the gonadotropins independent of the spontaneous LH surge, because you already have stopped the dominant follicle and the maturation of the dominant follicle. On the 5th day of treatment, you can start the GnRH antagonist, and you can decide to do the trigger with HCG or analogs of GnRH, and 36 hours later, you can do the oocyte retrieval, and this protocol can be used with very good results. The other protocol that we usually use is for patients during the luteal phase. And well, in these patients, the last menstrual period was more than 14 days. You see her in the ultrasound and you see that she doesn't have a dominant follicle, but maybe a corpus luteum. When you see her on the initial visit, well, you can start at any moment. At any moment. We usually recommend that if you're not completely sure, it would be better to measure the levels of progesterone to see if she already had the ovulation process. If the ovulation process has already been completed and she already ovulated, you can start at any moment the gonadotropins. Doesn't matter if it's FSH, recombinant FSH, or HMG. It would depend on the possibilities and the chances of having the medication close to and expensive, and well, the expenses for the patient and everything related to it. Some patients are recommended to use the GnRH antagonist, But even when the spontaneous LH surge has happened, sometimes at the beginning you should not use the antagonist because the progesterone is going to do the whole inhibition process of the triggering of these follicles. And when you measure the follicles and they're below 80 millimeters to 20 millimeters, you should do the trigger. And it doesn't matter if you use HCG or analog or agonist of GnRH. In 36 hours, you can also do the oocyte retrieval. And also the results are very good. The control of iron stimulation in women with estrogen-sensitive tumors is another challenge and should be dealt with caution. This can be achieved with addition of letrozole or tamoxifen to the above protocols to nullify the effect of rising estrogen levels during stimulation. And this is very important. And it actually doesn't matter the moment of the menstrual period for the initial visit, but you should start the medication always with letrozole at a dosage of 2.5 to 5 milligrams. And this medication should be maintained through the whole treatment or the whole process of hyperstimulations, either with gonadotropins, recombinant gonadotropins, or with HMG. And you can also use the GnRH antagonist to inhibit the natural trigger, and you can do the trigger with HCG, but it's also recommended to do the trigger with analogs agonist of GnRH. This diminishes the chances of needing more timing of letrozole. And when the oocyte retrieval is done, you should measure the levels of estrogens, and when the levels of estrogens are below 100, you can finish or you can stop the letrozole. The concept of continuous ovarian follicular growth, the random start of ovarian stimulation and the disarticulation of stimulation and embryo transfer led to the possibility of performing consecutive ovarian stimulation cycles and oocyte retrievals procedures in order to increase the number of oocytes available and possibly embryos in one cycle or in just 1 month. This is called double ovarian stimulation, and it consists of 2 successive ovarian stimulations in the follicular and ensuing luteal phase with 2 oocyte retrievals at the end of both ovarian stimulations. Use of a second ovarian stimulation during the luteal phase was first applied in poor responder patients. Kwan tested the possibilities of 2 ovarian stimulations in 2014 and showed good results in terms of more opportunities of retrieving oocytes. In these regimes, the first stimulation started normally in the early follicular phase, while the second stimulation started on the first day after the first oocyte retrieval, on which 2 or more antral follicles were identified. The first and second stimulations used 2 different regimes as follows. The first ovarian stimulation was conducted using a combination of clomiphene, 25 milligrams per day, starting on day 3 of the cycles until the triggering of ovulation. Letrozole 2.5 milligrams per day on day 3 for a total of 4 days, and HMG 150 units every day, starting on day 6 until the triggering of ovulation. The second stimulation was after the first oocyte retrieval provided as many oocytes and blastocysts as obtained in the first ovarian stimulation. In this experience, both the first and the second stimulations used a classical antagonist protocol with 300 units of FSH per day, using cetrorelix as the antagonist starting on ovarian stimulation day 6, and the GnRH trigger was done with agonist of GnRH, using triptorelin 0.2 milligrams when the follicular maturation was reached. The first and the second stimulations provided a similar number of oocytes, zygotes, and blastocysts, doubling the final blastocyst yield compared with a classical single ovarian stimulation assisted reproductive technology cycle. What we recommend now is that you can do the first ovarian stimulations using just letrozole or just gonadotropins. It's not necessary to use clomiphene either on the first ovarian stimulation cycle or the second one. And this process should only be recommended to poor ovarian patients or patients in cancer treatments that can postpone their beginning of the chemotherapy or radiotherapy for at least 1 month. And there's another thing is that we can start at the beginning when the menstrual period comes, the third, the fourth day of treatment of the menstrual cycle, or we can start it the other way. And it's on the luteal phase, we can start the whole protocol as the random start, but we just wait about 48 hours and then we would start the second ovarian stimulation and we'll do the oocyte retrieval almost 14 to 19 days after. The conventional ovarian stimulation, where the theory it's easier than the other protocols, where you just have the timing or you have enough time to do this whole process, would be recommended for non-oncological patients, usually that want to preserve for social or personal conditions or reasons. And then, you can wait until the menstrual period comes, and then you would start the whole process on the second or third day of her menstrual period. This protocol is different from the others because you actually don't need the endometrium to grow. So if you don't need the endometrium to grow, in either of the protocols that I already mentioned or this one, you can inhibit the triggering of LH or the peak of LH with progesterone. So instead of using just antagonists, you can also use progesterone. And when the follicles or the measure is above 80 millimeters, you can do the oocyte vitrification, or if she wants or she has a couple and she wants to, she can do embryo vitrification. And why do we all always try to make all the doctors, all the physicians that treat patients to speak about this? And the most important reason, or the thing is that the biggest threat for the fertility is age, is time. And women are increasingly seeking like a timeout until they reach the right moment of their life to have a baby, often postponing childbearing because of the lack of a partner, the lack of a stable partner, or maybe because of her career, financial issues. Maybe she just wants to travel around the world and that's it. But usually, the age at which women attempt to have their first pregnancy has steadily risen until the past 40 years. And right now, we're seeing that usually women want to have their first child at the age of 35 or above 35 years old. And the thing is that, nobody told nature this. And I have here a beautiful chart that shows that the probability of conceptions in patients below 35 years old is really high at the first 12 months. For patients that are at age of 40, these chances or these probabilities of conception diminishes. And at age of 45, the chances are really, really low. So we should recommend all the patients to ask some questions to themselves about if they want to get pregnant or not. And if they do, maybe the ovarian stimulation or the fertility preservation should be for them. Other thing, the risk of having a miscarriage increases with age. And usually at age of 35 years old, from 20 to 35, it's almost the same. But after 35 years old, just the chances of having a miscarriage increases rapidly. And as I usually speak to my patients, it's not just about the numbers, but also about the quality. And I usually use this example as a basket of oranges. When you see a bad when you see a bad orange, you usually don't pick that one up. You usually pick the other ones, and that's exactly what happens with the eggs. At the beginning, you usually choose the best ones. So after 35, you're just not having less numbers, but also the quality of the eggs is less than in other type of patients or younger patients. So this is I hope that a lot of you can use the same example or some similar examples to explain to your patients that it's not just about the number, but also about quality of the eggs. And this problem is not gonna diminish. As I'm showing you here in this graphic, this is the female labor force projections for 2030. And as you can see, almost half of women will be below, sorry, 1/4 of women will be below 34 years old. And almost 3/4 of women will be above 35 years old, which means that this problem is going to be increasing rapidly with years, because sometimes they look like this. Their couples look like this. Well, they look just healthy, they look younger. You cannot believe that that woman or that man has more than 40 years, but their sperms are just depleting, it's just not good quality, or her ovaries look like this. So the patients will always ask, doctor, is it worth it? And I wanted to bring a chart that it's very good for me also. I really like to explain with graphics to my patients. So here it says that there doesn't exist a magic number of eggs freezing or the success of freezing eggs. But if you have one egg at the age of 30 to 35, the chances of success of pregnancy are around 11%. If you have 5, you have 44%. If you have 10, the chances increases to 69, almost 70%. When you have 20, the chances are around 90%. And when you have more than 40, well, the chances are almost 99%. Well, not almost, 99%. But the thing is that with age, this success rate diminishes. And again, at 37, having one egg just gives her 7% of chances, 5, 29, 10, 50%, 20, 75. At age of 40, again, the chances diminishes. And above 42, the chances are really, really low. And not only because of the quality, but it's not easy to retrieve 10 eggs from a woman above 42 years old. So it is recommended that if it's possible to freeze eggs, she should freeze eggs early than 35 years old, or at least 37. There's another study from Cobble that this one is, I think, is the biggest of the reports related to the oocytes and the freezing of oocytes and the results of cumulative live birth rate. And this shows that above 35, below 35 years of age, the chances of getting pregnant, or the cumulative live birth rate are around 90%. When you have 10, it's around 60 to 70%. When you have 5, it's around 20%. But if the patient is above 35 years of age, she's going to have less than 10% having 5 eggs, and less than 40% with 15, and it almost doesn't change after 12 eggs. So when I'm I'm in front of a patient, I usually ask her, do you want to be a mother in the future, or is she determined not to be one? What is her current age? Does her finances allow her to undergo egg preservation treatment? Is there any family history of premature menopause? Or do she has any healthy problems such as polycystic ovary, autoimmune diseases, endometriosis, Turner syndrome, etc., etc.? And that is very important for them, because if any of these questions is yes, well, it would be recommended that she can freeze eggs before it's too late. So in conclusion, improving freezing techniques, ensuring safe outside transportation, well, to provide and extend the access of fertility preservations in large countries and low resources countries like Colombia or things like that, and minimizing the risk of fertility preservation strategies for the patients is one of the most important challenges in the future. And this is like bringing the future to the present. And right now we have very good freezing techniques. That means that we can have at least a 95% of survival rate for eggs and almost 99% for embryos, which means that it should not be a concern for patients. The transportation is another thing, and it's changing with the new politics and the more clinics that having almost the same protocols for freezing and thawing embryos and eggs. Well, you should transport them if you want to have a baby in a different country. For example, you can freeze eggs in Colombia and you can send them to the United States, to Europe, to France, to Spain, to England, even to Australia. And well, the risk of the process of or the risk of the stimulation related to ovarian hyperstimulation syndrome diminishes with the triggering with an analog of GnRH instead of HCG, which means that to recover easier and faster from the whole process. And well, she can start the process in case of oncology patients. She can start the process of chemotherapy 1 week after the whole process. Thank you for your timing and have a good day.